The main function of the kidney is to filter blood and remove metabolic waste. So the renal artery is going to give a large amount of cardiac output, roughly 20%, is going to flow through the kidneys each minute, so about a liter each minute. And so there is a renal artery coming in, so bringing oxygenated blood. And remember, the nephrons are out here in the cortex, so we have some vessels that are going to take that blood to the nephron. And by the way, hey, meet your first nephron right here. So we have the renal artery, and it's going to branch into segments, and then they're called segmental arteries. And when the arteries are running in between the lobes, then they're called interlobar arteries. They didn't really put it between a lobe, but interlobar arteries. And then notice it's going to make a turn, so they're called arcuate arteries, and then they're going to start sending out some rays, and so they're called cortical radiate arteries, and then they're going to get smaller. So we go, remember we have arteries, arterioles, capillaries. So when they get small, there's going to be a capillary for each of our filtration units. So each nephron has its own little arteriole going in. If it's an arteriole going into something, it's an afferent arteriole. Then there's going to be a capillary bed, and it gets a cute little name called the glomerulus. We'll look at them when we flip to lab. And this is where filtration is going to occur. And so the blood's going to be filtered, things are going to be filtered out and collected and processed by the nephron. Leaving that glomerulus is going to be an efferent arteriole, so efferent for exit. And then notice we have another capillary network. So these capillaries that are going around the tubes of the nephron are called peritubular capillaries. These capillaries, very important, they are going to be involved in that reabsorption. So things that are filtered out that we want to reclaim are going to go back into the bloodstream. And then also we have tubular secretion. So sometimes not everything filters out that the body wants to get rid of. So we have a way of exporting, sort of taking out our trash, if you will. Things that we don't want in the blood are going to be actively secreted. So from these peritubular capillaries into these ducts, and anything that makes it through the nephron in that ductwork is going to be collected and excreted as urine. Okay, so that's why we have all these vessels. Okay, so it's a combination. So we're filtering blood and then we're making urine. So these peritubular capillaries, and then when the blood leaves those peritubular capillaries and goes into these cortical radiate veins, it's been cleaned. Okay, so what's coming out is cleaned, processed blood. And so we have the cortical radiate veins, we have arcuate veins, we have interlobar veins, and for whatever reason, there aren't any segmental veins. Okay, so that one doesn't match. And then they'll all collect and go into the renal vein, and then the renal vein goes into the inferior vena cava, and then goes to the right side of the heart. So the kidneys are filtering blood and making urine, and all of these vessels are how that gets done.
Each kidney is supplied with blood by a single renal artery that arises on its respective side of the aorta, before dividing into 5 segmental arteries that enter the hilus. Within the kidney, each segmental artery branches into several lobular arteries. The lobular arteries further subdivide to form interlobular arteries, which branch off into afferent arterioles. Blood flows into the glomeruli through the afferent arterioles. Blood flows out of the glomerulus through the efferent arteriole. The afferent and efferent arterioles regulate glomerular capillary pressure by selectively dilating or constricting. The kidney's venous blood, now filtered, flows from the glomerulus via the afferent arterioles into the peritubular capillary network, a low-pressure, reabsorptive system surrounding all portions of the tubules. This arrangement permits rapid movement of solutes and water between the fluid in the tubular lumen and the blood in the capillaries. The peritubular capillaries rejoin to form the venous channels by which blood leaves the kidneys and empties into the inferior vena cava. Urine formation involves the filtration of the blood by the glomerulus to form an ultrafiltrate of urine, the tubular reabsorption of electrolytes and nutrients needed to maintain the constancy of the internal environment, and the secretion of waste materials. Filtration occurs as blood flows into the glomerulus from its afferent arteriole, and plasma moves through the glomerular capillaries into Bowman space. From Bowman space, The glomerular filtrate moves into the tubular segments of the nephron. Here, through tubular reabsorption, electrolytes and nutrients move from the filtrate back into the bloodstream. Here also, through tubular secretion, substances move from the peritubular capillaries into the urine filtrate. The filtrate concentrates in the collecting tubules, then finds its way to the renal pelvis, where it is directed to the ureter, the bladder, and the urethra for elimination. The kidneys perform an excretory function by filtering the blood and then selectively reabsorbing those materials that are needed to maintain a stable internal environment. The nephron is the functional unit of the kidney and is composed of a glomerulus, which filters the blood, and a tubular component, where necessary substances are reabsorbed into the bloodstream and unneeded materials are secreted into the tubular filtrate for elimination in urine.
All right, so the three processes of urine formation. I said blood is going to flow into the nephron by this capillary called the glomerulus. The blood is going to be filtered based on size. I'm going to show you. Just think of like a strainer, right? Just go make some pasta tonight, make some spaghetti, and then just watch your strainer and go, glomerulus, okay? That's how it works. So just based on size. So it's not selective. It's going to happen as part called the glomerular capsule. And then anything that fits through the strainer is going to go through the tubules, okay? And so what's going to happen in these tubules, things that we filtered out that we need back, like nutrients and sodium, some of our electrolytes that we want to get back, we're going to reabsorb. So that's called tubular reabsorption, and we're reabsorbing it back into the blood because that's where it was in the first place, right? Because we filter blood. Then there's some things that didn't make it through the filtrate, or we still need to get rid of it. And so we do that through a process called tubular secretion. So then we're going to go the other way. It's like taking out the trash. We are going to secrete unwanted things from the blood into the tubules to be excreted as urine. And so the directions are different. So when we're reabsorbing, we're going from urine back into the blood, and then we're secreting from the blood into the tubules. Like we're trying to clean our blood and maintain homeostasis. So the nephrons are here in the cortex, and there's about 1 million nephrons per kidney. I don't know who counted them, but there's a lot of them, okay? And like I said, they are solely responsible for this filtering and processing of blood and making urine, okay? And so like I said, see that they're located in the cortex. There are 4 parts to our nephron. We have right here, this little ball part is called the renal corpuscle. And like I said, we'll look at it underneath the microscope. But that word corpuscle, just whenever they looked at something, they didn't know what it was like a thing, a body. Corpuscle. Renal meant kidney in Latin, and corpuscle. So renal corpuscle is made up of that capillary bed. And then the cup that's going to collect the filtrate is called the glomerular capsule, or Bowman's capsule. That's the older timing name. So the urine gets collected, and notice then it's going to flow through some tubules that are kind of curvy, right? And so they named just this part right here, this curvy part, that's proximal to the renal corpuscle, the proximal convoluted tubule. So we abbreviate that PCT because nobody wants to say proximal convoluted tubule. It's a lot of mouthful, but it's telling you it's closest to the capsule. Then urine is going to flow through this bobby pin or hairpin. And so that is called the nephron loop, or the loop of Henle. Then you notice our tubes are going to start to get all curvy again, and so they call that the distal convoluted tubule. Okay, so DCT. And so that makes up the nephron. And then all of the nephrons are going to plug into collecting ducts, and that's what's running through the renal pyramids, and that's why it appears striped or striated in appearance. And then the urine will drain out those little renal papilla into the calyces, the renal pelvis, the ureter, and then be stored in the bladder.
The kidneys filter blood plasma, removing metabolic wastes, toxins, and excrete them in urine. During this process, they also maintain constant volume and composition of the blood, or homeostasis. Blood enters the kidney via the renal artery, which divides into smaller arteries, then arterioles. The arterioles get into contact with functional units of the kidney called the nephrons. This is where blood filtration and urine formation take place. The filtered blood then passes through a series of veins and exits the kidney via the renal vein. The urine is collected in collecting ducts and leaves the kidney via the ureters. Each kidney contains over 1 million nephrons. A nephron consists of two major parts, a glomerular capsule, or Bowman's capsule, and a long renal tubule. Renal tubules of several nephrons connect to a common collecting duct. There are 3 steps in the formation of urine: glomerular filtration, tubular reabsorption and secretion, and water conservation. Blood enters the Bowman's capsule via the afferent arteriole, passes through a ball of capillaries called the glomerulus, then leaves via the efferent arteriole. The afferent arteriole is significantly larger than the efferent arteriole, creating a blood flow with a large inlet and small outlet. As a result, the blood hydrostatic pressure in these capillaries is much higher than usual. Hydrostatic and osmotic pressures drive water and solutes from blood plasma through a filtration membrane into the capsular space of the nephron. The filtration membrane acts like a sieve, allowing only small molecules to pass through. These include water, inorganic ions, glucose, amino acids, and various metabolic wastes such as urea and creatinine, and make up the glomerular filtrate. The amount of filtrate produced per minute is called glomerular filtration rate, GFR. GFR is kept at a stable value by several feedback mechanisms within the kidneys, known as renal autoregulation. GFR is also under sympathetic and hormonal control. GFR regulation is generally achieved by constriction or dilation of the afferent arteriole, which causes the glomerular blood pressure to fall or rise, respectively. In a healthy person, the total filtrate volume amounts to between 150 and 180 liters a day. However, only about 1% of this is excreted as urine. The remaining 99% is reabsorbed back to the blood as the filtrate flows through the long renal tubule. This is possible because the efferent arteriole, after exiting the Bowman's capsule, branches out to form a network of so-called peritubular capillaries, which surround the renal tubule. The first part of the tubule, the proximal convoluted tubule, reabsorbs about 2/3 of the filtrate. In this process, water and solutes are driven through the epithelial cells that line the tubule into the extracellular space. They are then taken up by the peritubular capillaries. Sodium reabsorption is most important as it creates osmotic pressure that drives water and electrical gradient that drives negatively charged ions. Sodium levels inside the epithelial cells are kept low thanks to the sodium-potassium pumps that constantly pump sodium ions out into the extracellular space. This creates a concentration gradient that favors sodium diffusion from tubular fluid into the cells. Sodium is absorbed by symport proteins that also bind glucose and some other solutes. Nearly all glucose and amino acids are reabsorbed at this stage. About half of nitrogenous wastes also reabsorb back into the bloodstream. The kidneys reduce the blood levels of metabolic wastes to a safe amount, but do not completely eliminate them. Some of the reabsorption also occurs by the paracellular route through tight junctions between epithelial cells. At the same time, tubular secretion, where additional wastes and other solutes leave the bloodstream to join the tubular fluid, also takes place. The processes of reabsorption and secretion continue in the nephron loop, the loop of Henle, and the distal convoluted tubule. These parts of the tubule also have some other important functions. The main function of the loop of Henle is to create and maintain an osmolarity gradient in the medulla that enables the collecting ducts to concentrate urine at a later stage. The ascending limb of the loop actively pumps sodium out, making the medulla salty. The descending limb is permeable to water, but much less to sodium. As the water exits the tubule by osmosis, the filtrate becomes more and more concentrated as it reaches the bottom. The ascending limb, on the other hand, is permeable to ions, but not water. As a result, the filtrate loses sodium as it goes up and becomes more diluted at the top of the loop. The medulla is in equilibrium with the loop and hence has the same salinity gradient, saltier at the bottom. Reabsorption and secretion in the distal convoluted tubule are under control of various hormones. This is how the kidneys respond to the body's needs and adjust the composition of urine accordingly. The collecting duct receives tubular fluid from several nephrons. The main function of the collecting duct is to concentrate urine and therefore conserve water. This is made possible by the osmolarity gradient generated by the loop of Henle. As it gets saltier deep in the medulla, the filtrate loses water as it flows down the collecting duct. The collecting duct is also under hormonal control, so it can adjust the amount of reabsorbed water according to the body's state of hydration. For example, when the body is dehydrated, more water is reabsorbed back to the blood, and the excreted urine is more concentrated.
That is a great one to watch, maybe more than once. So we're going to break that down a little bit. All right, so the three processes of urine formation, it happens in the nephrons. And this is also a nice picture. So glomerular filtration happens right here in the renal corpuscle, and it's going to be based on size. It's not selective. So then what we need to do is we need to regain all the things back that are valuable to us. So nutrients and vitamins and ions. We are also, because this is chemistry, right, and we can't, it's not perfect, we also are reabsorbing some of our waste back. And that's just because, like I said, it's going to be chemistry and gradients and flow. The kidneys are going to filter blood and reduce those levels to a level that is not toxic to us. Okay, so they do clean up the blood, but they're not getting rid of all of our waste. So all the good things we're going to reabsorb back from the filtrate back into the blood. Then there's some things we want to get rid of, like our wastes. And two, you know that drugs are excreted in urine because that's why drug tests work. So a lot of our breakdown products or, like I said, things that are even from some of our foods that the body has no use for, we can excrete in urine. We don't have a lot of exit portals, if you think about it, right? We can defecate, which is just our digestive waste. So anything we have in excess or we need to get rid of is going to come out through urination. All right, and so we're going to actively secrete those things. So this first step that's going to happen in the renal corpuscle, like I said, it's just filtration. And we're filtering through that capillary called the glomerulus, and it has a very large entry, so afferent arterial, and a very small exit. And so that builds up pressure for this filtration to occur. And it's going to do it just based on size. I'm going to show it to you. It's very pretty. Then the capsule itself is a double layer. So think about a balloon, and if you shoved your fist inside of it, okay? So it has a visceral layer that is going to be on the capillary bed, and these cells have little foot extensions, so they're called podocytes, that are going to be responsible for making our filtration slits. And then the outer layer is the parietal layer, which is going to collect that filtrate. And we were talking about fenestrated capillaries that have the pores. This is where we have those porous capillaries, is in the kidney. Isn't it cute? That's pretty cool. It's a pretty cool looking strainer. So it's just filtering based on size. So like I said, this is what's happening. So the strainers, the glomerular capillaries with the filtration slits, and then what's going to be collected in that glomerular capsule will then flow through the tubules. Okay, it's 3 to 5 nanometers. So anything that fits through that strainer is going to end up in the filtrate. So if we look at this, like I said, it's going to basically filter our blood, the whole blood supply, about 60 times a day if you kind of do the math on filtration, right? And so what's going to get filtered out per day is 180 liters. We don't have 180 liters of water, okay? So we need to reabsorb that, all right? We are going to secrete about 0.6 to 2.5 liters of urine a day based on your hydration. Also, we're going to lose some of our proteins, and we don't really want to do that. Chlorine, sodium, bicarbonate, glucose, that's our food. We don't want to lose that. Urea is our waste. We're good with losing that. Potassium, we can lose some of that. We excrete a lot of it. Uric acid, these are our waste. So this is the amount that's filtered. This is the amount that's reabsorbed. And so this is what ends up in urine. Okay, so there's a lot of reabsorption, and then there's even going to be some secretion of things that are in excess or just things we need to get rid of. So good things for recovery are going to be reabsorbed through tubular reabsorption. So water, nutrients, so glucose, amino acids, vitamins, electrolytes, and any of our lost proteins. We want those back. So this filtration process, it's going to be all based on pressures, right? And so the pressure inside this glomerulus available for filtration is called the net filtration pressure. Net filtration pressure has to remain positive or nothing gets filtered out, and then our nitrogen wastes are going to build up and we're going to die. Okay, so it has to be high enough to filter, but of course we don't want it to be too high, because I just showed you those little podocytes and filtration slits. We don't want to blow holes in our strainer, okay, because that's bad, that's kidney damage. And so it's an interplay between blood hydrostatic pressure, which is going to be directly proportional to blood pressure. We know that there are proteins in the blood that are going to pull fluids back, so just like any capillary bed, right? We have the push out on the arterial side. Remember, we had the pick up on the venual side? So we have those two forces. We're adding one extra force because this capsule is like shooting a hose into a bowl. If you've ever done it, you know the water is going to splash up back in your face. Okay, so that pushes back. So we have the outward force from hydrostatic pressure, we've got the inward pull from osmotic pressure, and now we're adding the capsular hydrostatic pressure. We want to maintain a positive plus 10 millimeters of mercury net filtration pressure. That's perfect. We like that. That's enough to get rid of our wastes, and it doesn't damage our filtration slits. Okay, so it doesn't damage the kidneys. So that's the goal. So we filter out 100 liters of filtrate a day, but we're not going to excrete that. So the amount of filtrate formed is going to be directly proportional to that net filtration pressure. So the amount that gets filtered out every day is called the glomerular filtration rate, and it's roughly 125 mils per minute. And that's for males. It's a little bit lower for females, about 115 on the top end. But those two things are directly proportional. So if we change net filtration pressure, so if there's more pressure, we get more things filtered out. If pressure drops, we have less things that are filtered out. Okay, so you can think about it this way. So think about net filtration pressure as the force to filter things out, so across that membrane that allows our waste to be removed. And think of GFR, because we measure GFR in patients to see if their kidneys are working, as sort of the quota that the kidneys have to reach. Okay, so yep, I'm going to make this whole thing about, we're just going to imagine those little nephrons are like, an assembly line. Okay, and if you work in a factory, you usually have a quota, like you got to build so many pieces a day. All right, so glomerular filtration rate is the quota for kidney functioning, and it's 60 to 125 mils per minute of things filtered out of the blood, and that's for both kidneys. Things that affect net filtration pressure and glomerular filtration rate, obviously blood pressure. Okay, because that's that hydrostatic pressure. If there's something wrong with the osmotic pressure, so let's say the liver is damaged and they don't have their blood proteins like albumins, that could cause problems for the kidneys. And then kidney stones, kidneys in the name, got to see that would cause problems with the kidneys as well. All right, so kidney stones, some of you have models on your tables with little kidney stones in them. So kidney stones form, they are precipitated salts, so usually based on calcium. So if there's a kidney stone anywhere, what do you think is going to happen to capsular hydrostatic pressure? Where's the urine going to go? Out or stay in? It's going to stay in, yeah. So pressure is going to back up, okay? And so what's going to happen is you're not going to get a lot of urine formation, okay? So that's going to lower net filtration pressure and glomerular filtration rate because you got a blockage there. As people age, the amount of blood going to the kidneys decreases. So how do you think old people's kidneys work? How's their GFR? High or low? Low, yeah. Anything the body's supposed to do, it just slowly stops doing. You just remember that. So just think, what's the bad scenario? Yeah, that's what happens, okay? Because that hydrostatic pressure goes down, so that push isn't there anymore, all right? What effect would an increased systemic blood pressure have on net filtration pressure and glomerular filtration rate? Would that make it go up or down? Up. Yeah, it would go up. Yep. Except we can't have that because that would damage our kidney. Yep. I've tricked you. All right. So how the kidneys make sure that they meet their quota but don't damage their membrane, okay, like I said, so it's sort of this balance, is through renal auto-regulation. So one thing is through myogenic control, so myo always means muscle, and they have control, each nephron has its own control. It can control the amount of blood going in to that little filter, so through the afferent arteriole, and it can control the diameter of the efferent arteriole leaving. Okay, so we can control it through muscle controls, either by dilation or constriction. Then they can also have extrinsic controls. If things are too low, they're going to scream and they're going to release renin. We get renin, angiotensin, aldosterone, ADH, which will raise pressure. So they're pretty good when there's a normal fluctuation in blood pressure, because we have normal fluctuations throughout the day. Okay. Since they're controlling something, I'm going to give you one pass at this, and then we're going to shut it down for this one. So one pass, and this is where we're going to pick up on Monday. So you want to flip your sheet over. There's a picture of this. So now we are zeroing in. We are looking at the glomerulus and the glomerular capsule. And there's this magical place, which I know you're going to love the name, called the juxtaglomerular apparatus. It sounds fancy. Where it's located, so here we have our afferent arteriole bringing blood in, and then we have the glomerulus, which is where our filtration unit is, and then the blood leaving is the efferent arteriole. Then we know we have our proximal convoluted tubule, our nephron loop, and then right here is the distal convoluted tubule. It comes right adjacent to that afferent or arriving arteriole. So we're right here. So this is where the juxtaglomerular apparatus is located. And this is where we're going to monitor both pressure and filtrate. Like I said, they have to monitor their glomerular filtration rate because they have to meet their quota. All right, so what happens, there are cells there that are part of the distal convoluted tubule. So sorry, right here. These are going to be the juxtaglomerular cells. And then the macula densa cells are part of the tubule. I can do it from this picture. So the juxtaglomerular cells, they're part of the wall of the arteriole, and so they're renal baroreceptors. So when they get stretched, that means pressure is high. Okay, so if pressure is high, they can automatically relax, and then they can constrict to not allow blood into the filter. Okay, so I know like normal systemic, we have constriction that raises blood pressure, but just think about things going into a filter. Okay, so if we close off the pipe going into the filter, that shuts it down. Okay, so if it's too high, then we're going to get vasoconstriction. If these cells don't get stretched, that means things are too low. Okay, and then they're going to try to dilate and open this really big to allow the maximum fluid or blood into this filter. And then this is going to be really small, so to build up pressure. So they're going to try to sort of build up pressure just inside their own little filter. Okay, so that's what the juxtaglomerular cells do. The macula densa cells are right here where the tubule is, and what they're doing is they don't have like a radar gun, like they can't really tell the speed of things flowing, but they can monitor sodium. So like how salty is our urine, okay? And so if they notice that, okay, this is like really, because we're absorbing sodium right before we get there, like this is almost water, like we've absorbed all of our sodium, they know things are moving slow. That means, hey, we got to pick things up. And if they kind of notice like, oh, wait, we haven't absorbed any of our sodium, this is way too salty, then that means we need to slow things down. So those two, they're monitoring, are we meeting our glomerular filtration rate? So like I said, they're going to monitor it. If sodium is too high, that means the filtrate is moving too fast and things need to slow down because we don't have enough time for reabsorption. And we would be making way too much urine. We'd be losing too much stuff. Okay, so they go, okay, vasoconstrict. So they can talk to the afferent arteriole because they constrict. We've got to slow down. If they notice it's too slow, so they're down here, things are too slow, then, okay, we can adjust. We can open that up to try allow blood in, but also we need more systemic pressure. So that's when they release renin. And we get renin, angiotensin, aldosterone, and that's going to increase blood volume. So just through myogenic control, controlling the amount of blood going into the capillary and the amount of blood leaving, and then just by that extrinsic control by the release of renin or not releasing renin. okay, but they have to meet their glomerular filtration rate, their quota. And I always remember macula densa cells monitor and control cells through autoregulation. Macula densas, like the Big Mac, they're salty and they tell the JG cells what to do. And the juxtaglomerular cells release renin. So like I said, the juxtaglomerular cells, like I said, they can monitor pressure. Like I said, they're baroreceptors. So if they stretch a lot and they detect that blood is going into there and it's too high, they can constrict. If it's too low, then they can dilate. And then like I said, they're the ones that are going to release renin if things are too low. So Big Macs are the ones they can tell if things are salty or not salty, and then they're the ones that tell the JG cells to release renin or not. Like I said, so if they open this really big and constrict this, that'll build up pressure inside that renal corpuscle. Yep, and that's why we do this twice, because I see the look on your faces, and that's why I made you a chart, okay, or a table. If everything's fine, then glomerular filtration rate is just perfect, and we are removing our waste at just the right level. If there's an increase in systemic blood pressure, that means we would be making way too much urine. It would be just going way too fast. So the macula densa cells, they can tell because there's high salt, fast urine flow. The juxtaglomerular cells, they can vasoconstrict to slow that blood going into the filter, to slow it down, and then they wouldn't release renin. If there's a drop in blood pressure, that means we are not filtering. That's a problem, okay? We're gonna get a buildup of waste. So macula densa cells sense that it's not salty, it's moving really slowly, and then the juxtaglomerular cells can vasodilate, okay, allowing more blood into that glomerulus, constrict the leaving arteriole, and then also release renin to raise systemic blood pressure. And that's where we're going to pick up on Monday.